Dear Chair, dear audience, let me present my 18th month progress on the PhD thesis of New Frontiers in the Diagnosis and Management of Cutaneous Malignancies. I am Lili Gulyás, a medical doctor and a PhD student at the Department of Dermatology, Semmelweis University. Here you can see my two ongoing projects, and let me first talk about my first one, which is investigating the predictive value of different biomarkers for post-diagnostic events in cutaneous malignant melanoma. Cutaneous melanoma is the fifth most common malignancy in the US, and depending on the primary tumor stage, the 5-year survival can vary between 98 to 22%. We can say that every 1 out of 3 of all melanoma patients will have a disease recurrence. In the clinical practice, there is no consensus on which biomarkers have the highest predictive value. Of course, there are some biomarkers we use in the clinical practice, like LDH and S100B. However, there are wide ranges of biomarkers in the literature with a potentially higher predictive value. And that's why our aim is to compare the predictive value of serum biomarkers in melanoma to predict disease progression and patient survival. Our clinical question is, which biomarkers have the highest predictive value of patient survival in melanoma patients? We use the PEO framework, where our patient population is melanoma patients, and we'd like to compare serum biomarkers in the outcome of death and survival. Our hypothesis is that novel serum biomarkers have higher predictive value for the prediction of survival in patients with melanoma. Here you can see the final search key that we used for the systemic search in 3 main databases. Here you also can see the flowchart of the selection, and in the end of this process, we have 185 eligible full texts. I'd like to share you some results. Here you can see pooled hazard ratios of overall survival with different serum biomarker level associations. Hazard ratios are unitless numbers which express a probability of an event happening, in this case the patient survival. So for example, in the case of LDH, the 2.29 hazard ratio means that the patients with elevated levels of the biomarker had 2.29 times less chance to survive than those who had lower levels of this biomarker. If we look at those results in different therapeutic subgroups and in different stages of the disease, we can see some differences among the biomarkers, and let me highlight some of these. First, the circulating tumor DNA levels in patients who got stage 4 disease and got immunotherapy strongly correlated with the overall survival of a patient with the 4.64 hazard ratio. And we can see that LDH remained a reliable predictive marker in the targeted therapy groups and patients who got stage 3 to 4 disease. Also, an interesting finding on neutrophil to lymphocyte ratio, that it significantly correlated with the overall survival of the patients in the immunotherapy-treated patients. Also, let me show you some results on progression-free survival. In the first forest plot, you can see the pooled hazard ratios of the biomarker level associations with the progression-free survival in every patient. And if we look at those patients in 2 therapeutic groups, we can see that the circulating tumor DNA levels correlated the most strongly with the progression-free survival of the patients in the immunotherapy-treated patients with a hazard ratio of 4.12. However, in the targeted therapy-treated patients, the LDH was the strongest correlator, and the results were also statistically significant. Our study has some strengths and limitations. The strengths are it's a comprehensive analysis, and the measurements are objective. However, the limitations that the study types were very different, and in some cases the cutoff values were not the same, so we couldn't pull them together, and the population was very heterogeneous. So based on our results, we can conclude that in all patients, LDH, circulating tumor DNA, and neutrophil to lymphocyte ratio predicted the overall survival and progression-free survival very similarly. However, if we observe them in subgroups, we can say that in stage 3 to 4 patients who received immunotherapy, the circulating tumor DNA levels and the neutrophil to lymphocyte ratio are the most promising predictors of survival. However, LDH is a better predictor in those receiving targeted therapy. So the implication for practice is that the usage of LDH as a general tumor marker is still advised. However, monitoring neutrophil to lymphocyte ratio in patients receiving immunotherapy is recommended, and to introduce circulating tumor DNA measurements in the future to clinical practice. The implication for research is that which biomarkers are worth further investigations, and unified cutoff values are needed in the studies, investigation of neutrophil to lymphocyte ratio in all therapeutic settings, and to validate circulating tumor DNA measurements. Here you can see my manuscript status, and we'd like to submit it on February to JAMA Oncology. And here you can see the progress of my first project. And let me shortly talk about the second project, which is investigating the safety and efficacy of systemic therapies in locally advanced or metastatic basal cell carcinoma with the methodology of a systemic review and a meta-analysis. So basal cell carcinoma is the most common malignancy in Caucasian population, and the majority of the cases can be treated successfully through various therapeutic procedures. However, there are some cases where these lesions have progressed to a point where these traditional treatment options are no longer feasible. And these lesions can cause disfigurement, also intracranial penetration, affecting not only the physical appearance of the patients, but their quality of their life and potentially their life expectancy. For these advanced cases, some novel systemic treatment options are available, like sonic hedgehog inhibitors and PD-1 inhibitors. And therefore, our aim is to assess the therapeutic efficacy and safety of systemic therapy in locally advanced and metastatic basal cell carcinoma patients. So our clinical question is, are PD-1 inhibitors effective for patients who fail to respond sonic hedgehog inhibitor therapy? We use the PICO framework for this clinical question, where our patient population are locally advanced or metastatic basal cell carcinoma patients, and we like to compare PD-1 inhibitors to sonic hedgehog inhibitors in the outcome of efficacy and safety. And we hypothesize that locally advanced or metastatic basal cell carcinoma patients, PD-1 inhibitors are an effective and safe therapeutic options after treatment failure to sonic hedgehog inhibitors. And the clinical and research implication would be to find the most effective and safe therapy for these patients after failing the first-line systemic treatment. So in summary, you can see that I have two ongoing projects. The first one is about predictive value of different serum biomarkers in malignant melanoma, and the second one is assessing systemic therapies in locally advanced or metastatic basal cell carcinoma patients. Both of them is a systematic review and a meta-analysis, so the methodology. And thank you for your kind attention, and let me wish you a good afternoon with a quote from a great movie, Star Wars: do or do not, there is no try. So thank you for your attention, and I'm looking forward to your questions.
Congratulations. Are those predictions also good, or have you found any project, any predictive value of those biomarkers for actually the recurrence of melanoma?
Thank you for your question. So when we first started this meta-analysis, we wanted to observe the recurrence, but there were so low dates, so we couldn't find any to put them together, and the survival was what we could observe, yes. But that was our first thought, to be honest.
Or actually, are there biomarkers that can help with the initial diagnosis? Because that's one of the crucial parts to diagnose it earlier.
Yeah, of course. So from these biomarkers, there are some research on circulating tumor DNAs in stage 1 to stage 2 patients, and they says that it helps the diagnosis. So actually, they target very specific mutations, and it can show early from also blood samples. So yes, there are some. I think the circulating tumor DNA was.
So congratulations. And my first question is, what kind of mutations we have to see in the primary or in the metastatic lesions when we want to treat melanomas patients?
Mm-hmm. So as as far as I know, the BRAF mutation, but in some cases they observed the NRAS and the KRAS, so I think these mutations were for the circulating tumor DNAs, but the BRAF is the most common. But
the circulating DNA, it's not available now in melanoma, just in
from histology,
lung cancer, and also we have to see PD-L1 expression and TRK and c-KIT in acrolentic melanoma. Okay, and what kind of treatment can we give for the patient in first line when she or he has BRAF mutation?
So BRAF/MEK inhibitors like vemurafenib and abratinib, Zelboraf, so this kind of treatment in first line.
Okay, and do you know the side effects for this treatment, for the targeted therapies? Usually have photosensitive rashes and toxicodermas for this type of patients, and the QTc interval has longer. Okay, thank you.
Thank you for your questions.